Well, hello and good afternoon, and welcome to this, our final session of the MRF HIV STI Echo series for 2020. I am Dr. Gregory Boyce. I am your facilitator this afternoon. I just want to welcome you and give you Christmas greetings to everyone who is with us. And just saying a big hello to Conrad, our master-in-chief behind the scenes. And thanking again Dr. Edwards, our director, and Belinda, our psychosocial expert, and our guest who's here with us today. So we're going to delve in pretty quickly, and we're going to have a conversation about neurocognitive disorders in HIV, which is an issue that is going to become of increasing importance as our patients age and develop comorbidities that some of us we may not be able to necessarily recognize early on. So I'm going to turn on the presentation. Give me just a second. And with that, I will turn it over to Ms. White to start today's session. Ms. White.
All right, thank you, Dr. Boyce. Good afternoon, everyone. Today we'll be discussing neurocognitive disorders in HIV. Next slide. So of course, we acknowledge that the content of this presentation is not intended to replace any personalized medical advice, and we acknowledge program funding as well. So the learning objectives for today would be to define neurocognitive disorders according to the Diagnostic and Statistical Manual. The second is to explore the cognitive domains included in the criteria of neurocognitive disorders. The third, to discuss the HIV neurocognitive disorder criteria outlined in the DSM, which is the Diagnostic and Statistical Manual version 5. And finally, to review the identification of neurocognitive disorders at the MRF. So firstly, the neurocognitive disorder category in the DSM-5 includes the group of disorders in which the main clinical deficit is in cognitive functioning. So neurocognitive disorders is an actual chapter in the DSM that persons refer to for several different disorders that may arise, right? So neurocognitive disorder is not finite, but rather category of disorders. So the core feature of a neurocognitive disorder is the cognitive deficits that are present are acquired rather than developmental. Therefore, the cognitive presentation of an individual should reflect a decline from the previously obtained level of functioning. So this basically means that an individual would not have been born with these cognitive deficits or presented with them during early childhood, but rather acquire them throughout their life. And so their presentation should be different from the way they were before they came to you, whether it be a couple months or a couple years. It depends on the state of their progress of the disorder. I also want to point out before you move forward that several mental health disorders, for example, schizophrenia or bipolar disorder, they all include cognitive impairments, right? So someone with schizophrenia may have impaired judgment and insight. Also, they may have deficits in various cognitive domains. However, the primary feature in schizophrenia is not a cognitive one. The primary feature in a neurocognitive disorder must be that cognitive deficit. And so you find that schizophrenia falls within the psychotic, I want to say, category of the DSM, as opposed to the neurocognitive category of the DSM, even though it has even though the presentation of schizophrenia and other mental illnesses include cognitive deficits. So in order for a mental illness or a neurocognitive disorder to be diagnosed, these are the 6 domains that are considered for that diagnosis to be made. So complex attention, executive functioning, learning and memory, language, perceptual, motor, and social cognition. So I'm just going to run through each of these domains and give examples of them so that we're all on the same page in terms of understanding what exactly these domains entail. So complex attention, an individual's ability to sustain attention as well as engage in divided or selective attention. It can be evidenced by their processing speed. So sustained attention is engaging in one task, like an assessment for a significant period of time without a break in attention. Divided is engaging in two tasks, like having a conversation and writing simultaneously within the same time period. And selective is maintaining attention to one task, like an assignment, despite the competing stimuli. So you may notice this a deficit in this domain if you have a client before you while you're doing an intake interview and they're unable to maintain attention throughout that entire interview. They get distracted by other presenting stimuli, or they're just unable to process what you're saying to them quickly. So that's what we talk about when we say processing speed. When you're presented with stimuli, the amount of time that it takes for you to process the stimuli presented to you and for you to respond to it, it is usually delayed with persons who have a deficit in complex attention domain. So next is executive function. This is an individual's ability to plan and make decisions. It is also evidenced in the individual's working memory, mental flexibility, and self-control. So planning. This is considering the sequential steps that may be taken to complete a task, like exiting a maze or completing a puzzle. Decision making is the process of selecting a logical choice from available options, like the way in which an individual spends their money. Working memory, the ability to hold information for a short period of time and manipulate it, like repeating a list of numbers in ascending order. And finally, mental flexibility, the ability to maintain or shift attention to tasks depending on the demand, like changing schedules to accommodate a new task. So let's put it in context at the clinic. You may notice that a client before you has a difficult time in planning how they take their medication or arranging their medication to take it appropriately. And it may also be evidence in them repeatedly missing clinic appointments, which can display a lack of insight toward the importance of attending clinic and getting their medication. That goes to decision making. So the first one is plannings, right? So in terms of talking about or considering an individual planning how they take their medication, what time they take it, with what meal, how they arrange the medications to ensure that they don't take too much or too little, that speaks to planning. And the decision making could speak to clinic attendance as well, where they do not have the insight to recognize that this is important and I need to attend clinic. So you may find that their decision making is somewhat questionable with that. And I'm not saying that everyone who defaults clinic or misses clinic dates have an executive function deficit. But if you notice that it is a significant pattern of behavior and their rationale for missing clinic is not a plausible one, then we do have to inquire and investigate further if there is a deficit there in that domain. So next is learning and memory. And individuals' short-term working and long-term memory are identified here. The process of encoding new information. So this first aspect of this first blurb, it speaks to learning, which is the process of encoding new information, like a list of words and recalling them with or without a cue. So a cue could mean I'm giving you a list of words for you to read, and then I ask you to recall them for me, but you're recalling only the colors or you're recalling only the words. So I give you a semantic cue. And so that is indicative of someone's ability. It is indicative of their memory capacity and also their ability to learn. And also the semantic and autobiographic and implicit learning are also noted within this domain. So implicit and autobiographic, semantic, all of those bits of information are stored and they're not within our conscious mind, right? So we have learned things like the motion that we do to brush our teeth, and other activities that we engage in is somewhat automatic to us, and we recall it. What's a good example? Let's say the alphabet. Someone may start to sing the alphabet automatically if you ask them to, without them having to think about it. So it's sort of an automatic response. So that too is included within this cognitive domain. So a deficit within this domain may look like an individual having a difficult time remembering tasks that may be done in a day, or following a list of items to be bought, and they require frequent reminders. So let's say they forget that they have to cook food, they forget that they have to clean their house, they forget to take a shower. And they may need a list to remind them to do those things, or they need someone to support them in doing that, or they go to the grocery to buy items and they get terribly confused with what they have to do at the grocery. What are the items to buy? What are the items they have not bought as yet? It's also interesting to note that implicit memories that I mentioned before, they are relatively preserved in severe forms of major neurocognitive disorders like Alzheimer's, unlike recent memories. So you'd find someone who has been diagnosed with a major neurocognitive disorder like Alzheimer's, they're able to recall, they're able to engage in the activity of brushing their teeth, they're able to recall autobiographic information from many, many, many years ago. However, recent information, something you may have told them a minute ago, they're unable to maintain or retain that information rather. So next we have language, which is an individual's ability to express themselves and understand others through the use of language. So expressive language, like naming of items, grammar and syntax, and receptive language are significant aspects of this language domain. A deficit in this domain may look like an individual having noticeable difficulty in word finding, avoiding the specific names of persons or things, but rather using general phrases like that thing and general pronouns like them and they. So we may take this for granted when speaking to someone and think that they're just having a lapse in memory at that time, but it's something for us to note. If we as clinicians are meeting with someone and we notice that, they always seem to be searching for the right word to say, and sometimes for very basic activities or very basic items, individuals that they live with, they may refer to them as that guy, that woman, that boy. That is something for us to explore, because it can mean a deficit within that cognitive domain of language. And perceptual motor, I think this is the second to last one. So the perceptual motor domain is an individual's activity to navigate their environment using their senses and motor skills. So integrating perception and purposeful movement. So visual perception, visuoconstructional praxis, and gnosis are all aspects of the perceptual motor domain. So this is a very interesting domain because it really means that we are taking in all these stimuli around us and using our motor skills to navigate the environment that we are in. And so an individual who has a deficit in this domain can have a very difficult time in navigating an environment that they are even familiar with. So they may trip a lot, they may fall, they may have a difficult time in putting things together. So visual constructional, it refers to the ability to use our visual senses to construct, in addition to our motor senses, to construct or build or put together an activity. So let's say putting together blocks. A good activity that is used for visual constructional is the clock drawing test. And this test is something that is done with persons to determine if they have memory loss, where you ask them to draw a clock for you and you see that they have to use visual constructional. So there's some geometric aspects of drawing a clock. And in the In their inability to do so, it is evidence that further investigation is needed. Yeah, so a lot of research shows that this is a well-founded test and is a reliable one to use, particularly for visual constructional skills. Then we have the praxis, which is just using muscles and movement with purpose in mind. And also gnosis is the ability to recognize objects perceived by the senses, particularly somatosensory sensation. So for example, you may have someone close their eyes and then you write something in their hand and you ask them, what did I just write in your hand? You say, I'm going to write a number in your hand, and they close their eyes and you write a number. You say, so what number did I write? An individual without impaired gnosis would be able to say, okay, you wrote the number 8, I felt it, right? Without them even seeing it. However, a deficit in this domain, it would be pretty difficult for someone to do that. So here I have a deficit in this domain may look like an individual having a difficult time in engaging in tasks that they were previously familiar with, like using tools, appliances, or driving. They may require support or direction when completing a task, or may find themselves lost without this support. So it's like just navigating the home. Someone with a major neurocognitive disorder may have a difficult time navigating the home that they've lived in for several years, and they may need support in someone directing them and saying, but this is what to do in order to use this appliance, this is what to do to use this tool. So a deficit in this domain can be really, really critical to everyday life. Oh, sorry. So the final one is social cognition. An individual's ability to recognize emotions in others and consider another individual's mental state, which is theory of mind, this includes thoughts, desires, and intentions and experiences. So emotional recognition, this may be evidenced in an individual identifying the emotional experience of another, which may be identified through cues like facial expression or tone of voice. And theory of mind is evidenced by an individual's ability to identify a rationale for another person's behavior, like being able to indicate why someone else may be feeling angry or sad after they have witnessed the triggering event. So what I mean by triggering event is, for example, you present the client a story and you say, well, this is what has happened. And you ask them, so why is this individual in the story feeling angry or sad? They have the information before them. Someone with a deficit in this domain may have a difficult time in saying, well, they are angry because this happened, or they are sad because this happened. It's difficult for them to recognize the thoughts, desires, or intentions, even the experiences of someone outside of themselves. And this is very present in not only neurocognitive disorders, but neurodevelopmental disorders as well, particularly like persons that have autism. And so this is something pretty important for us to consider as well. If we have a client before us and they don't seem to recognize emotion or be able to know or are able to know how to respond to it, that is something for us to look into, as well as them being unable to identify even in their interactions with you. If you are a bit put off by what they've said, or you're a bit confused and they're unable to recognize that and respond appropriately, that is something noteworthy and worth investigating. So this slide, it's a summary of the criteria in the DSM5 for mild and major neurocognitive disorders. So both mild and major neurocognitive disorders have similar criteria. And on the right of the screen, you'll see those similarities, particularly number 1, which is a decline in cognitive functioning from a previous level of performance. So as I mentioned at the beginning of the presentation, this is a critical part. It's a neurocognitive disorder because there must be a decline in level of performance, cognitive performance, that is. The second is cognitive deficit interferes with the individual's capacity for independence in everyday activities, for example, paying bills or managing medication. So for major neurocognitive disorder, this is a definite yes. And you'll notice that I have notes and asterisks for mild. That asterisk basically means that the individual, it does interfere with their independent living, but there is an effort made to manage. So let's say, for example, an individual find that they do have to make an additional effort to navigate things like paying bills, managing their medication, and various tasks. And so they engage in additional activities to sort of help them navigate it. So for example, at the clinic, when individuals have a difficult time in managing their medication, the social workers do a nice calendar for them and they give them post-its and write down dates. And so that is a task that is sort of like a buffer activity that is done to help them navigate managing their day-to-day activities. So it's sort of a compensatory strategy. The third here, we have the cognitive deficits do not occur exclusively in the context of delirium. And delirium is an abrupt change in cognition, including attention and awareness, and it's not permanent. It lasts a short period of time, days or weeks, and it cannot be better explained by a pre-existing or evolving neurocognitive disorder. That is delirium, right? So the cognitive deficits that is being experienced by the client or the individual, delirium must be ruled out. Once delirium is ruled out, then we could consider other neurocognitive disorders. And finally, the cognitive deficit is not better explained by another mental disorder. So you'd find that in order to make a diagnosis of a neurocognitive disorder, we have to go through the process of ruling out. We rule out delirium, we rule out another mental illness or other health issues that could impact the individual's cognition. So, major or mild neurocognitive disorder due to HIV infection. So this is a diagnosis that is included in the DSM5. So of course, the criteria for major or mild neurocognitive disorder must be met, which is what we went through at the previous slide. And the person must have a confirmed HIV diagnosis. And then criteria 3 is the neurocognitive disorder is not better explained by non-HIV conditions, including secondary brain diseases. And the neurocognitive disorder is not attributable to another medical condition and is not better explained by a mental disorder. So you'd find that in order to make a diagnosis of a neurocognitive disorder, it's quite the process, because we have to go through due diligence to ensure that we are not misdiagnosing this individual. We have to ensure that there are no other illnesses that can account for their presentation, particularly if they have an illness like HIV. There may be several factors that are impairing their cognition and their performance within these various cognitive domains. And so we have to rule out all other possible conditions before we give the diagnosis of a neurocognitive disorder. And finally, identification of neurocognitive disorders at MRF. So clients with cognitive deficits may be identified through the use of screening tools, particularly the mini mental state exam, which may be administered by a physician or the psychologist. And so the use of the screening tool, it basically highlights flaws in cognition. It highlights an individual's deficits in various areas. And clinical interviewing is also very critical and is conducted by the psychologist myself, where you are able to detect flaws or deficits in various cognitive domains while you're discussing different challenges or just conducting the clinical interview with the client. Their presentation, you may notice, and I have noticed on more than one occasion while meeting with a client, you find that, there's a deficit in their language domain because they don't quite understand what exactly you're saying to them, and you have to repeat what you're saying, or they have a very difficult time in articulating what they mean or what they intend to ask. They have a difficult time in expressing themselves entirely. And then you also pick up on some executive functioning deficits where you may find an adult who is 45 needing support with money management, needing support in coming to clinic, needing support in various things. And all of those are indicators of a possible neurocognitive disorder. So finally, a client who's identified as having a cognitive deficit that may qualify as a major neurocognitive disorder, they are referred for further testing to rule out the neurocognitive disorder due to HIV infection. These referrals are made by physicians. Treatments would be undertaken based on the results received, and this usually encompasses the medical and social intervention. So this basically means an individual, once they've been identified as having a cognitive deficit and requiring support, we do the due diligence, send them for various tests to be done to ensure that if there are other medical conditions that could be interfering with their cognition, and we go through that process of ruling out other mental disorders, other medical conditions, particularly related to HIV. And once we've come to a conclusion, then we begin the intervention. And that intervention, of course, will entail medical support. But any individual that has been diagnosed with a neurocognitive disorder, they would also require some sort of social intervention, because a lot of what I said before would have been the individual requiring support and guidance in terms of executing tasks, in terms of navigating their environment, etc. And so the intervention has to be twofold. And to review, the neurocognitive category in the DSM-5 includes the group of disorders in which the main clinical deficit is in cognitive functioning. This deficit should indicate a decline in functioning. Second, the basis for the diagnosis of a neurocognitive disorder is found in 6 cognitive domains as outlined in the DSM-5, which are complex attention, executive functioning, learning and memory, language, perceptual motor, and social cognition. And finally, prior to making a diagnosis of a neurocognitive disorder, other medical or mental health disorders should be ruled out.
All right, that's the end of the presentation. Thank you so much. I'll just open the floor for questions. Remember, you can unmute yourself and ask your questions in through Zoom, or enter your questions in the chat box.
I don't have a
Belinda,
question.
you could just give us an idea. Okay. No, I just want to get an idea of the mini mental status examination now. What kind of questions you'll ask, so people can understand what you're asking that.
So in the mental state exam, when you meet with the client, you assess their orientation to time, place, person, and self. You assess if there are any perceptual disturbances, of course, meaning if they're experiencing hallucinations, which include auditory, visual, tactile, olfactory hallucinations. When those hallucinations are occurring, we look at their language to determine if it is organized or disorganized. We look at their composure and their affect, if their affect is flattened. So a lot of the mini mental state exam, what I use is the brief mental state exam, which is a bit shorter. It does include questions to ask. For example, have you ever had a strange experience like hearing things that other people cannot hear, or seeing things that other people cannot see? So those are direct questions. But then you also have a lot of observation that is stated on the form as well. So affect is something that is observed. I usually ask the client to pull down their mask, which I should not do, for maybe a couple of seconds, just so that I can see their entire face for a couple of seconds while they're speaking to me, so I can note if it is flattened or not. The mask makes it kind of tricky. But then the organized or disorganized speech is something that is also observed and not something that you ask the individual directly. So the mental state exam is a screener comprised of direct questions as well as observations.
some of the words they use like affect and stuff. I'm not sure some of the audience will understand. You have to kind of break it down a little bit for them too. All right.
Sure. So affect refers to the individual's, I want to say their facial response to what you may be saying to them. So while you're speaking to someone, you may notice that their face is in cohesion with what they are saying. So part of the description that you can make is mood congruent. So if someone is telling you happy things, chances are they may be smiling at you, and that is their facial affect, right? If they're sad, their face may be a bit down, they have a frown, etc. And so that would be mood congruent. Their facial expression and what they're saying and their experience is aligned. Incongruent would be, or flattened would be, while they're speaking to you, there seems to be no facial movement, no facial response, no facial expression at all. And so that is what affect means. My apologies if if anyone doesn't understand anything that I've said, please feel free to let me know so I could simplify.
I just wanted to share a point in ruling out some of the other conditions with specifically talking about cognitive language domain. Like, one of the things that I know happens within the MSM community, especially amongst older MSMs, is that in order to not reveal their sexual preferences, persons in the past would have made definitive choices to always use they and them rather than tripping themselves up and using he at the wrong time. So you might find that that is something that older MSMs kind of always do, whether they're talking about male or female, always using they and them, so that they're never in a situation where they unknowingly out themselves through using he in what they would term to be inappropriate.
Yes, thank you for that, Conrad. And I do acknowledge what you say. However, in terms of the language domain, this is somewhat broader, right? So let's say an individual has a deficit in this domain. They may be trying to refer to this bottle here, and they refer to it, so you can't see the bottle, this bottle here, and they may say that thing, right? I was using that thing, right? And it's a common object. Or they may be talking about a doctor that they're familiar with at the clinic, and they may say that guy, right? So it's more of a general experience when you're talking about any of these cognitive domains. They're not limited to talking about sexual experience, any history, etc. But you just have to pay attention to. So let's say, for example, you're talking to an individual and they seem to always use general pronouns when talking to persons, but they are able to articulate themselves very, very fluently when talking about other things. And so that may lead you to believe that they don't have a deficit within the language domain, but they are doing this because it helps them navigate that the situation that they're in at present. And so you can address it with them, you can have a conversation with them just to find out and clarify. Yeah? I hope that helps you understand. Yeah? Awesome.
So that's a good question, because sometimes it's difficult if I'm seeing, for example, a patient for the first time, and you notice they have a lot of difficulty with language and with things that you would find simple, but they have difficulty. How can I put it? But processing.
Yeah.
Right? I mean, the first time you're seeing them, you have no other point of reference.
Mm-hmm.
How do you distinguish between something that is sociocultural, like low education level, low IQ, versus something disordered? When do we, have that person that's referred to you for an objective assessment? Am I looking at something that is actually due to the HIV disease?
Yeah.
Or, because if it's something medical, like a toxoplasmosis, had a stroke, or meningitis, well, okay, this may be that. But otherwise, they're well, and they can't quite grasp certain things. At what point do we say, okay, this person needs some more in-depth assessment? Yeah,
I think when you see someone for the first time, it depends on context, right? So you may not have the time to go through a lengthy interview with the person, and ask them about their history, etc. So I do think that it calls for some observation. I do think that sometimes, given the environment that we work in, it could be intimidating, especially if it's the first time. And so you may have just nerves, right? And the person is not sure what to say. However, I would say if you've seen this person on 2 or 3 occasions, and there are other factors at play, so you could ask on the second time you've met them, do you have a history of mental illness within your family? Are there any other illnesses within your family? And I do believe that is a question that you would ask at a general intake, right? So once you have those predisposing factors, another one could be limited educational background. So you may not ask that up front, but on the second time meeting with the individual, if they say, well, you know, I only have primary school level education, that may help you to understand where they're coming from, right? And they just don't have the vocabulary to articulate themselves. So I would recommend giving it some time in terms of observation. However, if it's an elderly person, then we do have to pay more attention to that, because there may be other factors at play there in terms of their genetics and their biological makeup that we do have to investigate, right? But I believe that we should consider more than just the language domain, right? So let's say the language domain. So persons can have a deficit in language, but their cognition in general, their executive functioning is fine. Their social interactions are fine. And so we can't limit it to language only. If someone presents with a language deficit or having a difficult time expressing themselves, yes, we monitor it, we take note of it, it's definitely noteworthy, but we also look at the other cognitive domains as well. And if you notice that there's an across-the-board deficit in executive functioning, they have a difficult time in processing what you said, their language, they have a difficult time socially as well, then you may consider, okay, let's investigate further on what's happening here. Maybe there's something at play that we must consider. Yeah.
And what would you say would be best practice in terms of dealing with persons who have a significant amount of neurocognitive deficit? Because you referenced it quite nicely that there are some patients that we see fairly often who will never be able to cognitively manage something as relatively simple for someone without a deficit of taking medication every single day on time, especially if it's someone who would have failed first-line therapy and taking this one twice a day, 2 of these twice, this one at midday, and there's no way to go around that. How do we move through that?
Well, I do think that we are making a great effort in terms of what the social workers are doing, right? And I do think that individuals, what we try to do is strengthen the social support that they have at home, whether it be their family members that could come by if they can't afford to have live-in care. There's a case now that the social workers and I discussed yesterday in terms of referring the client's family to go to the government-assisted where they get live-in care from the government, GAP, the GAP program. So that is where we turn to. We turn to strengthening their social support, because when they come to us, it's just one time they're seeing us, but they need day in, day out support. And sometimes family members cannot afford them that. So I do think that is one avenue we have to look at when we do recognize an individual has that executive function deficit and they're unable to navigate situations and they're just a daily living on their own as much as they will allow us to, because there are some clients, they are very they don't want to have someone staying with them, they don't want to have that help. But if they are open to it and their family is aware of their HIV status and willing to lend that support, I do think that is something that we should consider. Yeah.
Thank you very much. All right, so